Thank you guys for coming to the Healthcare Advocate Summit. This talk, mapping the copay journey in pharmacy and medical benefit settings. So I am really, really well versed in medical benefit settings, and I am constantly learning in pharmacy benefit settings. So we'll get through it. We'll talk about it. We'll have a good time. A little bit about me for those of you that are new. If you've heard this already, I'm sorry. I'm Elizabeth. I'm a licensed practical nurse. I'm a certified professional coder. I'm a prior auth certified specialist and a board certified patient advocate. Got a lot of things going on with patients and advocacy being the number one thing. I'm also the CEO of Medico and the president of NMAPA. I have nothing to disclose. I am here on my own free will. Little description about this. The cost of healthcare in the United States continues to rise, and medications are no exception. Patients are often faced with access and cost barriers to obtain the appropriate benefit, navigating both pharmacy and medical. This course provides a roadmap on how to help engage, empower, and navigate patients through this copay journey. So we've talked a little bit about copay in the first talk, talked a little about copay and the different types of Medicare structures in the second talk. Now we're just going to talk about copay and some more copay. So we want to talk about pain points, right? I think that's how we kind of bond, we commiserate. We talk about, this is really hard. How do we make it better? We find solutions. How to communicate those solutions back. Describe copay assistance programs, education to patients and helping them understand, and then areas for improvement. I think as a medical community, we all have really great ideas, but they get lost. You talk about it at the lunch table, somebody writes about it on social media, but how do we really take these things, come together and make a difference? So how do you streamline it from manufacturer to patient and then back from patient to manufacturer, right? Two-way. So I've been very lucky in my career to work on a couple different drug launches and to see how, from a provider side, what that looks like, what that relationship is. So manufacturers, I mean, research goes on years in the making when that drug finally comes, gets a name. And in my role, what do I get asked the most about? Forms, access, hub services, copay cards. Great, I can talk about all of those. What doesn't get asked is, it's like, do you like this form? Well, let me tell you to make a form easier. So there's a lot of manufacturers out there now that are really being progressive and asking, what would work for you with your patient and your provider to get a patient started? We're able to voice how we feel. We're able to share that feedback, and that's really valuable. So then by the time this drug launches, gets to our healthcare provider, our providers are extremely intelligent. They're ready to write product, right? What's the worst thing that happens is when a provider walks out of a room and goes, so which one can you get them on the quickest? That's not allowing the doctor to be a doctor, right? But having that investment in that time from advocates, their knowledge, hey, this is what's going to make access better. When the provider says, I want the patient on this drug, that advocate's prepared. They know how that's going to work. I can do this. They feel much more empowered to get those forms in and do what they need to do. Thus, they know the program. So guess what? They're going to tell the patient about it. They're going to talk to the patient. They're going to educate the patient. The patient's going to have that open communication and be willing to communicate with that provider because they've had that extra time. So the patient then knows, okay, if a 1-800 number calls me, I'll answer. Or I will wait till you call me to tell me my prior auth is approved. Everyone's trying to help, right? We want everyone to help. Is that necessarily the case? We wish it was 100%. Healthcare is in a major staffing shortage across the board right now. COVID has really depleted resources, long wait lists due to teacher shortages. We don't have the same amount of nurses, physicians, and other providers coming out of school. But nurses, multiple clinics, what happens though in that situation, right? You've got strong advocates wanting to get something done, but what about the other departments? Billing, credentialing, managed services. Sometimes your front desk is separate. You have a separate admin or a management team. What can then happen? Communication barriers, right? Prior auth may not talk to billing. Billing may not talk to financial navigation. Financial navigation may not talk to the provider. You're chasing these loopholes and it can be inconsistent. Inconsistent process equals inconsistent results. So some of the other challenges that we face, talking about right drug, patient, and time, okay? Out-of-pocket max. How many patients truly know their out-of-pocket max? I know my deductible, but what's my out-of-pocket max? To be honest, I should probably know that, but I don't. Documentation, right? I'm really big about my providers documenting. We're busy, we're short-staffed, so on and so forth, right? All the documentation required may not be there. Procurement. If you don't know how you're going to get the drug, what do? That's when prior auths on the wrong benefit or don't get done, things like that. And then billing. I will say, as a certified coder and dabbling on the billing side, I could talk my way around J codes all day long. Billing is tough, especially getting into ICD-10, bundled codes, so on and so forth. If you're not confident in your billing, you're not willing to put the research in, things happen. So the education of a biologics coordinator and a billing department combined together, that's an unstoppable force. But they don't always get to talk to each other. So that's kind of a problem. So then after you've done all this work, patient's gotten a drug, you're on the claim side of it, right? I've been in, I said earlier, probably close to 400 practices. And in some of these practices, claims and post-service is a whole separate entity, right? They're their own little bubble, accounts receivable, whatever you want to call them. They don't talk to anybody else. So payments don't come through. CoPay cards don't get run. Denials come back on EOBs and they just kind of write it off, right? I'm gonna fight for every penny. So a write-off to me is no bueno. And so then that communication falls apart and we have all this money left. It's not a good use of resources, right? If every commercial patient that rolls through your program gets a CoPay card, but they never touch it in 12 months, what good is that doing anyone? So where is it optimal for CoPay and coupon to live? Okay. Some people are firm believers in let that bill come through, let the patient get that EOB, and then we'll worry about CoPay assistance. Who does that? Who waits till after post-claim? Anybody? Who does CoPay or applying for grants before claim? I'm on your side with that. When I'm getting benefits on a patient and I'm learning what their out-of-pocket max is, that's when I'm looking for CoPay assistance. Because sometimes, especially if you're talking about grants, it's going to take a little bit of time and you may be waiting. On the pharmacy side, there are plenty of pharmacies that work with manufacturers that say, when a patient calls and we have to tell them how much the drug costs, we'll tell them about the CoPay program. How many times does that actually happen? That a pharmacy will say, hey, we have a CoPay card for this drug. It's rare. Does it happen very often? Nah. So, and then take it a step further, right? Some pharmacies also have patient assistance programs. How many times do they bring those up? Yeah. I didn't know pharmacies had patient assistance programs until about 2 or 3 years ago. Boy, did I feel stupid when I learned that. So in a lot of larger health systems, they've actually started building out financial navigation programs. And these financial navigation programs are huge. It is a group of dedicated people who look at what the benefits are for the patient, look at the drug, they know the different assistance types, foundations, and programs, call the patient, talk through their entire profile. Here's what would work for you. Here's what's not going to work for you. Here's how we apply for this, the whole gamut. That is such a value. But again, we go back to healthcare, it's short-staffed, not always wanting to fund that kind of stuff. So there becomes a struggle of there's this really great idea, but no execution on it. In a large system, copays, coupons, assistance programs are sometimes separate. I don't work in a hospital, but I do enough talking to hospitals to know there's a large system in my area that are trying to move from individual sites to one, condense everything together and centralize this process. It's not going all that well. Clinic, usually you have one person that does it. So it's inadvertently kind of centralized. And this says not for nurses on here, but I would go against that. Nurses are great at copay assistance. So some resistance, it's time consuming, right? Copay assistance, running a copay card shouldn't be as hard as it is, right? But we can't do anything until that EOB comes back. So we have to wait. Healthcare is on a delayed payment system. And not that when you go to Walmart, you buy your groceries, right? You know what you're going to pay, you pay it, you're done. In healthcare, we bill it, we wait, we hope we know our fee schedules, we hope we know what our allowables are, and then we'll collect. So it's very different. So a lot of times we can't be as proactive as we want to be. Thus, it creates that kind of time-consuming process. There's a million portals, and I don't have portal fatigue. I love a portal. Saves me a phone call, a fax, things like that. But for a lot of people, the portals can be draining, especially if they're looking things up, trying to figure out which drug goes where, or if you cover, an oncology suite or something like that. The other option from this is there's different ways to submit. Certain programs have EDI transmission, so it works like an insurance file. When you're going to a manufacturer website or you're going to a portal, right? You're trying to figure out what to do with your copay cards. How do you figure that out? Me, I call my rep. I call my firm and say, hey, what am I supposed to do? But if you're new or you're naive or you haven't had that interaction with your rep yet, you go to a website, okay? The goal would be to find it in 3 clicks or less. How many websites, and I'm not talking to those that are in the pharmaceutical industry, but advocates, how many times have you gone to a manufacturer's site and found what you need in less than 3 clicks? Nope. And that can be hard. That is time. So going back to that time piece. There are some of us that love to give a lot of feedback. When our FRMs come in the office, hey, this took me 5 minutes to find one form, or hey, this took me 5 minutes to submit this copay card. So talking to your FRM, having that communication is important. And then asking them, is there a way to make it better? I think that's the #1 problem we face. No one asks the question. So communicate with your FRM, say, hey, I could not find what I needed to. It took me more than 5 minutes. It was more than 3 clicks. How can I get this copay assistance filed for? Portals, fax, whatever that may be. And then how does the copay program or assistance program actually work? That's always my question. Geraldine up here talking about Medicare. There are certain programs that have assistance, not a copay, that work for Medicare, but it's not written in that little tiny font down at the bottom. So how does it actually work is my next question. And then how to get a paid claim. So I submit it, right? In my world, funds are loaded on a card. I run the card, I apply it, so on and so forth. That's not how it works across the board. But if you're in medication access, that's the most likely scenario you're used to. So if it's something out of the ordinary, how does this work? Can you explain this to me so that I know what I'm going to do? Quick poll question. So with CEs, we have to ask these questions. So I need participation, guys. Which benefit is easier to use copay cards with? Show of hands, pharmacy benefit. Okay, medical benefit? Doesn't matter. Yeah, 6 to 1, half dozen the other. Anybody want to share why they think pharmacy benefit's easier? There you are, Tara. Hey. Yeah. So again, I come from the medical benefit side mostly. So I'm used to waiting. I'm used to all that. But you're right. And there's the safety of that, right? They're not going to ship drug without using it. So pharmacy versus medical benefits. Everyone in here knows the difference, right? Everyone in here can explain the difference between pharmacy and medical. This is fantastic because that doesn't always happen. So one of the things I teach a lot about is the difference between those and what they mean. So all infusion product copay programs need pharmacy billing info, medical billing info. You got to know both sides. It's very important. You can't do a complete benefit investigation if you only try to do one side. You got to have all options, because what if it comes back a carve out? Well, then now you got to send it back in, do the second benefit investigation. Always look at both. Some infusion brands copay assistance is not set up to be utilized through pharmacy benefits, right? They're medical benefit drugs only. So some pharmacy benefit pain points. Patient exhausting insurance max benefits. Patient exhausting copay card max benefits, and pharmacy billing information not properly labeled on the card. That's usually not properly on the forms too. So something that I was not aware of was an AOB, right? You exhaust all of your pharmacy benefits and you ask for an assignment of benefits over to the medical. I never had to do that in my career. That is something that I've learned about recently. And I can only imagine, especially on the oncology side, that's tough, right? It's another form, it's more phone calls, but if it's not advertised, not talked about, you guys may all know about it, but as an advocate, I didn't. That's huge. That's a way to move your patients over and continue their therapy. So let's talk a little bit case study style for copay assistance, right? Expensive specialty drug, high patient out-of-pocket copay, copay is approved, insurance max benefits are reached. Well, your copay max benefits are reached. Now the patient must pay full price for all their prescriptions. Is that total care of the patient? So they've maxed out everything, but they've got copay assistance. So what happens? Then they use up all their copay assistance. What do you do next? You're applying for free drug, right? Patient's got nothing left. Well, then what happens? Let's say it's like, I don't know, June when you get this patient. all this copay assistance, right? Copay cards are usually good for 12 months. So you got 6 months of the year, but then what happens in January? Well, their deductible rolls over. They're going to max out their benefits again and either move back to free drug, or you're going to be chasing this game every single year. So being aware of this stuff ahead of time, knowing what that copay looks like for them and what that copay assistance will carry them through is extremely important. Now to my wheelhouse. Medical benefit reimbursement, bundled payments. Have a process to still be able to pay on these claims. So bundled payments are really important, especially knowing your coding for this. Patient starts treatment based on copay assistance. Two sides to this story, right? Again, I talked about a provider walking out of a room saying, which one can you get first? I also have providers ask, and I always say, clinically, what's your choice? And then I'll tell you which has the best copay assistance program. Because I want my providers making a clinical decision first, and then I will work with the patient second. Yeah, I want to keep my job, okay? But that is a really big, important part of it, is understanding the patient's need financially. So especially in a drug class where there's lots of competitors, you kind of have that freedom. But when you're talking about a drug that doesn't have a competitor, or it's the only one for that indication, you have to know what's available to that patient, and you have to be able to communicate that back to your provider. How to submit high percentage of claims rejected when faxed. My least favorite thing is when I fax copay assistance requests over, or copay cards. Fax is so antiquated, but then they never get them. And then I get close to that timely filing thing, wondering what happened. And then the high percentage of claims, just kind of a good thing, approved the first time when uploaded. There's a manufacturer whose copay card portal is from the Stone Age. It is a dinosaur. But I know that every time I upload the patient's EOB that's appropriate, there's a patient responsibility, I'm going to have an approval in 24 hours. So I'll brave the dinosaur because I know I'm going to be able to adjudicate that claim for that patient pretty quick. The challenges on the fax side, the fax claim, I don't run into these too much, but there's not really a notification, right? Unless you're checking that portal every single day. Sometimes they'll fax you an approval, but if you've ever worked in a larger system or a larger healthcare group, how many times that fax actually get to that person? Now it goes to a queue and then is passed around, could be a couple days, so on and so forth. So some pain points. Marketing materials. For those of you that were here earlier, I said go to the internet, look it up. Caveat, it could be outdated, right? There are all kinds of marketing materials for copay assistance. Doesn't mean they're in date, doesn't mean that's the current program. That can be really frustrating. I have helped offices move, rearrange, clean out, and I have taken my hand into cabinets and I have swiped every marketing material out of it into the trash because I don't know when they were from. Maybe there's some little like 2016 down at the bottom, but it's not kept up to date. And that really falls on two sides, right? I don't blame pharmaceutical companies, I don't blame the office, but I do blame lack of communication. So when I'm working with a practice, I always say, ask for new updated handouts. Always give your patient a copay card handout. Make sure that they have it. Whether or not they read it, that's on them, but you've given it to them. You've given them the tools to invest in their own health, but make sure they're up to date. Most important. Patients given the option to receive a check or card. So a lot of these kind of programs are going away, but they are really tough. One of the programs that I've worked with is I'm trying to run a patient's copay assistance. They have a physical card, right? So if anybody in here knows about PCI compliance, you do not write credit card numbers down and keep them on a sticky note on your desk. How many medical offices have you been to and seen that? Somebody in billing has got a whole list of credit card numbers, usually copay card numbers. You can't do that. So some people use things like Pay Easy. You can have a patient sign a waiver. You can store those copay card numbers. But when the patient gets an actual physical card, you file their copay assistance, then you have to wait for the patient to come in. There's another delay of payment there. They forget their card. They don't bring it to the appointment. Or my least favorite is when they mail the patient a check in the patient's name. The patient may not come back. So those are kind of tough. But I also think it's tough when it's mailed to the office in the patient's name and you have to wait for the patient to come in and back sign the check so that you can cash it. So very, very complicated processes. Everybody does a little different. I understand compliance is different at every program, plus and minuses there. Third-party copay vendors, being educated on what to look for. The third-party copay card vendors, and I understand they're there. It's really hard to work with your rep, your local FRM, and say, hey, I'm struggling with this copay card. and they don't have a great point of contact with the copay card. There's such a disconnect between them. And again, back to me being spoiled, I always ask for a main point of contact, especially if I'm calling on a lot, because that disconnect can hold up hundreds of patients at one time. So again, compliance, I understand, but really making sure that the manufacturer has a great relationship with that copay card processor really saves a ton of time and removes that kind of like patient calling, oh, when's it going to go through? What are you doing? J-codes do not spell out drug name. When someone's new to this process, yes, it does not have brand names in there. It has generic names. And if you don't know them, it's tough, right? So if you're trying to find a drug name in a J-code and try to search some database, you may not find it. I would love to find an EOB that has like, it just has the J-code, but I'd love to find an EOB that spelled it out. That'd be really cool. Does anybody's software do that, or EHR, like on your claims? Yeah, has like the J-code and the drug name next to it on your EOB. Yeah, maybe one day. And if you retire off of that idea, just don't forget your friend here, okay? Looking at another version of this, medical benefits mandating to use pharmacy. I come across this all the time and it makes me want to scream. Carve out, whatever you want to call it. Coupon and copay follow the medication, so then it goes to the pharmacy benefit. Impact on medical deductible and yearly out-of-pocket. I love copay assistance and I love medical benefit because in the disease state I work in, we see patients every 3 months, sometimes more. We are doing testing, we're doing other things that impact their medical benefit. Accumulators aside, right? Like, let's not think about those. I'm bringing a benefit to that patient. I can argue medical benefit all day long and what that does for asthmatics. But when I have to push it over to the pharmacy benefit, I still have to see that patient every 3 months. I'm still doing several $100 tests every time, but everything's going to that pharmacy benefit. I'm not really bringing any value to that patient, right? I understand that there's two sides to that story, but that's where I take that. Manufacturer having options to help with infusion costs. So back to that medical benefit thing, right? I've been pushed to the pharmacy. That patient is coming every month, 2 months, whatever it is, but they're having to pay administration charges every time. Those can add up. Back to that billing and coding side and using copay assistance, I see a ton of practices. In my line, it is 96401 versus 96372. I will die on the stairs and tell you a pre-filled syringe should not be used with 96401. Work component, RVUs, all that go into it, does not equate. Okay, I'm in asthma and allergy, so I'm not going to go too far, but in this space, right? We pull something out of the fridge, we sit it on the counter for 20 minutes, let it come to room temp and we inject, right? There is patient monitoring, there's this. There's no mixing, there's no other handling. 96401, even though it has monoclonal antibody in the title, even though it has biologics in it, does not constitute pulling a syringe out, putting it on the counter. That code does reimburse $100, give or take. Multiple units, some payers will cover. If your copay assistance is $1,000 a year for administration coverage, and that patient has a high out-of-pocket, what happens? That $1,000 that you give is going to be eaten up really fast. So even if I'm able to keep the patient in office, they've got copay assistance, but say it's coming from the specialty pharmacy, the patient's going to run out of administration coverage. They're still going to be paying $100 to get their injection. That's not a proper use of a copay assistance program, especially when it comes to the coding side. So for the manufacturers that do have that option to cover administration and infusion costs, that's great. But then it falls on the practice or the facility to know how to properly code for that. I know, controversial. Sorry, guys. All right, question for the audience. What is your favorite method of submitting copay assistance? Show of hands for portal. Okay, fax, the old reliable fax machine. Email, who emails copay assistance? And I added other because this is one I love, which is EDI with ACH or EFT. Yeah, okay. So a coupon or a copay program, when's it working, right? Instant online portal or web enrollment. I love when I talk to a patient, and I'm very, very particular how I document this. When I'm talking to a patient, I never enroll them in copay assistance without them having be on the phone or just spoken with me, because it's a financial decision for that patient, right? So I call them up, hey, I see that you're going to have a large cost for this drug. This is available. Can I help you apply for it? And I document that I talked to them, they approved, so on. I love when I can enroll a patient. I also really love when I submit enrollment to a manufacturer and the patient's eligible, they automatically enroll. I think that's great. Sometimes the patients don't understand that. They get a letter or a packet in the mail and a card if they're sending physical cards, and they're like, well, why'd you guys send me a credit card? They don't understand. Back to patient education, we should probably warn them about that a little bit better. But I wish there's a little more explanation that went into those programs. What doesn't work? Requiring to have a physical card before enrollment. So if I'm going to submit that, again, we talked about that physical card. And then requiring the patient to enroll, right? You won't talk to me. Patient has to call and enroll on their own. That's tough because not every patient's going to pick up that phone and call. Not every patient's going to go online and fill that out. And how many offices or places, facilities you've been to that's tried to like go around that, and all of a sudden they've got iPads and like little rolling carts and sign up over here to try to get the patient before they leave. Great, I understand that logic, but is that customer service friendly? Are we really educating our patients? Is that doing them the right service? So some more recommendations here. Manufacturer representative come and meet with the account, right? Back to that FRM position. I've said it so many times today. You guys are so sick of hearing it, I'm sure. Lean on your FRMs. I lean on mine heavily, right? That is their ability to talk to you, to work through that, and to educate. Have your rep set up follow-up accounts. So once a quarter, I work with my field reimbursement team, and then usually twice a year, I had bring in sales, separate departments, to go over, I say the original pitch, right? Like what you learn when you get into this role. Tell my entire team again. Let's start over. Let's make sure we're not missing something. Because as I shared earlier, sometimes I forget about those patient assistance programs, right? The free drug programs, things like that, because you get so busy in the chase. We get into the day-to-day grind of how this works and what we're doing and in between patients and so on. We sometimes forget. So setting up recurrent educational, just, hey, run through it again with me 6 months from now. Let's talk about it. Also set them up with your provider. And if you're in a larger system, get them in with the pharmacy, get them in with revenue cycle, get them in with your financial navigation program, and then determine how to fold all of that into your existing process. I love buttoned up SOPs. I've said that before. But in a larger facility, access can be hard. It can be difficult for representatives to get in there. So go ahead and get it on the books, let people know this is happening, and make sure that it happens continually so you get that education. And a lot of times, if you push it out 6 months, something's changed. There's a new form, there's a new program, there's a new this. Oh, some more recommendations. CoPay portal, right? If you are not signed up on any of your portals, ask your representatives to sign you up, okay? There's a lot of people that just ignore the portals and love paper. I can't stand a cluttered office. Don't talk about my sticky notes on my desk, those of you who know me. But I don't like enrollment forms everywhere. So please, sign up on those portals. CoPay cards, know them inside and out, forwards and backwards, and back to that portal setup. One really interesting point on here is share interest to beta test. I will always volunteer myself, my group, the previous practice I was with. Hey, you got something new coming? Let us try it. I love to give feedback. We probably all know this by now. But if your facility is looking to change, looking to improve, looking to take that next step, volunteering to do something different or to try something out, that's your chance. And if you're in an advocate role and you're looking to progress your career, one of the best ways you can take the next step in your career is saying, hey, how can I help you as a manufacturer or as my representative provide that feedback? I want to be a valuable asset. At the same time, I want your help. You forge that relationship, I'll tell you what, it'll take you a lot of places. I started that way. Re-verification season, okay? CoPay cards and re-ver season, that's a forgotten part, right? I get my, I know October, November's coming. We all start talking about re-ver and Blizzard, and I know it's gonna be a lot of work. I tell my husband every year, we're not doing anything the 2 weeks after Christmas because that's my busiest time of the year. I lie, everything shuts down, but I'm just trying to warn him that the blizzard is going to be bad. It's okay. When you get your stack or your list of patients, usually manufacturers provide you something or there's something on their portal. Everyone goes through, talks to their patient, did your insurance change? Did this happen? They forget to look at copay card balances. Thinking about what's going to happen after January 1st, that deductible rolls over. Does the copay card roll over, or does it go 12 months and sign up? So what happens if that patient rolls over and you're left with, you know, a huge balance there? So when you're doing your re-verifications, strongly recommend go through and check your copay card balances. And if you see there's going to be a problem, immediately contact the manufacturer and see what can be done. Maybe you need to start looking for assistance. A lot of funds open on January 1st. Start looking for those kind of things. How are you going to do re-verification is also really important. I have made the mistake of waiting to the very last second on re-ver. Get checked for my patients until February. That doesn't really help me if I need benefits for January 1. So make sure that you are looking at what that process is going to be like. Set some healthy goals, right? Patients are our number one. We all know that. I know we kind of like say that out loud, like, oh, we're here for the patients. Blanket understanding, we know that. But how can we truly live up to that, right? And it's not just doing the job, it's satisfaction. Surveying patients, talking to patients. When I, as an advocate, work with a patient, yes, sure, I get an approval at some point, or maybe I don't. Where I truly derive my success and what I'm chasing, or the high that I'm chasing in a situation, is that patient can look back and say, this person really helped me. No matter what the outcome, I felt supported, I felt encouraged. Maybe I learned something, maybe I didn't, but she was there for me and we got through it. That's what I define success is in these situations. Through that, having that relationship with the patient, they've learned something. The patient is more likely to be adherent to drug, right? If they have questions, if something does go wrong with billing or copay, they're going to call me and ask me. And I can reassure them it's going to be okay, we're working on it. So they're more likely to come back for their next injection or infusion. For the healthcare provider, right? When the patient comes back for an appointment, patient's been on treatment, they can truly assess, is it working or is it not? So you're helping the patient more from just a financial standpoint, you're helping them in their healthcare journey. Some references and all that. Before I close, kind of a wrap up on this copay thing, right? Ask questions. That's the number one tip I can give you in this. Every copay card program is a little bit different. They are not a one size fits all. There are compliance and regulations that go into it that is one size fits all, can't break them, can't change them. But how they work, how you submit, and what their timing is are all different. Take all that information, sit down with your FRM and say, okay, this is your drug. Let's map out what your copay card program is and keep that list for yourself so that you know, and it'll help you improve your copay card program. This event that we're here for, there's different manufacturers, there are different programs. I challenge each one of you to go and ask those questions. Hey, can you tell me what the time limit is for filing for your copay card program? You may learn something. They may all be the same. That'd be really cool. I don't know. But ask those tough questions, and they're not tough. They want to talk about those things. That's how we learn. So that is copay cards in a nutshell. Who's got questions?